I just want to begin with what an incredible weekend this has been. Such an adrenaline rush. It's been marathon style. And I know you guys have been working nonstop and have put in a lot of work. So I'm really excited to see how these final pitch sessions will go. Our track A judges consist of Jan, Jack, Santosh, and Ryan. I will open up the floor to them so that they can introduce themselves briefly to you. I'll start with Jean.
I'm Jean Kern. I'm SVP at Bayer Pharma and leading the digital and commercial innovation. I'm actually French, which explains the name, and working in Berlin.
Great, thank you, Jean. Next we'll go to Jack.
Hey, great. Thanks everybody again for all your hard work this weekend. I'm Jack Roy. I'm a practicing physician, also on the management teams of Partners Healthcare and Mass General Hospital, where I do value-based care and then health tech for Mass General. I'm assistant CMIO. And I'll say my early career down the digital health path started at one of the early hacking medicine events. So was in your shoes many years ago. It's such a wonderful event.
Thanks, Jack. Santosh?
Hi, everyone. My name is Santosh Mohan. I'm the Managing Director of the Brigham Digital Innovation Hub, also known as the iHub. We support a number of digital initiatives at the hospital, have been working on both the COVID surge and now the recovery and reimagining efforts, supporting them with digital solutions. My academic background is in bioinformatics and clinical informatics, and I've worked in product, provider, and consulting spaces, and looking forward to all the solutions that we'll be discussing today.
Thanks so much, Santosh. And Ryan?
Hi, everyone. My name is Ryan Krohn, and I'm the Director of Innovation and Commercialization up here in Portland, Oregon, for early cancer detection. My background is in med tech. I was a Stanford Biodesign Fellow a handful of years ago, and I started a women's health company called Medora. Happy to be here.
Thanks. Nice to meet you, judges. All right, so I'd like to just go over some of the hackathon process that you've all been experiencing this past weekend. You first started with problem pitches. After you heard the problem pitches, you had a chance to mix with other participants and form teams. Then you went straight into brainstorming and hacking those problems. You received feedback from mentors, and you reiterated your solutions based on that feedback. And now we're here presenting your final solutions. Some of the judging criteria for your presentations will be the impact your solution has. Is it a real problem? Has the potential for widespread public health impact? Does it address an important challenge identified within this COVID-19 challenge where we are opening up and we'll see a surge of non-COVID patients being seen for the first time in many months? Does your solution have an innovative, is it innovative? Does the team provide a convincing rationale for why their solution may work? And do they address significant technical issues relevant to their problem? Does the solution consider user experience, interface, and service design? Next, your solution should be implementable. Could the proof of concept, prototype, or preliminary vision be executed upon? Is it sustainable, viable, and feasible? Could the solution possibly be implemented by one of the challenge partners? And lastly, we'll be looking at your presentation style. Was it an effective presentation? Does the team have what it takes to carry the project on and implement it? Does the team have a diversity of backgrounds that lend themselves to the solution area? And after seeing the practice pitches, I feel that a lot of these judging criteria have been met, so I'm excited to see the finals. So some of the logistics of the final presentation is that your presentations will be recorded. Multiple team members can present and answer the Q&A. Just raise the hands of the individuals who will be speaking and we will unmute you. You will have 3 minutes to present and 2 minutes for Q&A. The order you present is random. We will tell you that you are up next, so you will have 5 minutes to prepare. Make sure to read the slides because it will have who is up next. If you will be presenting for your team, please raise your hand and you will be unmuted. When it is your turn to present, you will unmute and turn your video on if you would like, and I will flip your slides for you. You can simply say next and I'll move forward to advancing your slides. Michael will give you a 1-minute warning. Please pin his video to keep him in view while you present. The judges will pick 4 winners per track. So if you're unsure of how to raise your hand, you can simply go to the participants section of the Zoom meeting, and there you will find the drop-down box for raising your hand. And then we will unmute you. You'll present for 3 minutes and then Q&A for 2 minutes. And judges, if I'm moving along too fast and you don't have time to fill in your judging criteria form, just let me know and I'll slow down. Thank you. So to begin, we'll start off with team A48, Hospitality. And then up next will be team 36, Triage Plus.
So, Amy, are you presenting the team?
3 of us are presenting, Jordan, Catherine, and me.
Got it. So I just recommend if you could pin my video. So on the top, I think bottom right of my video, you can pin me and I will show you a green screen when you reach 1 minute, and then 2 minutes, I will reach you this yellow. And then when you're done after 3 minutes, I will show you this red background. So make sure you pin me.
Perfect, thank you.
Thank you.
Pleasure.
So hello and good afternoon to those of you on the East Coast. Today we're Team Hospitality and we're going to be presenting our project. Next. Next. So as communities begin reopening across the nation, patients are seeking non-COVID related healthcare and are often afraid of being infected themselves. In addition, hospitals are not being transparent about their capacities, and they're also losing fortunes due to patients' fear of infection. In fact, hospitals across the country have been reporting a 50% decrease in ER volume since 2019. Next. Next. Thus, the problem we are facing today is how might we minimize contacted spread, but still get non-COVID patients the care that they need. We want to make healthcare more welcoming with Hospitality, a web app that helps non-COVID patients decide whether to seek in-person help or not, and where to seek help based on waiting room capacity. ERs and urgent care centers can use our web app to update their capacity and layout. We hope that non-COVID patients will use our app to get medical attention when necessary without feeling afraid of being infected, and that hospitals will use our app as a digital front door to share information with patients and keep non-COVID patients safe. To track room capacity, hospitals can link to our web app with an existing electronic tracking system, manually track the capacity, or connect to an existing security camera, which my teammate Jordan will talk about next. Next. Okay, I think our teammate's mic is not working, so I can take over. Oh, wait, he's still, what? Okay, so as you can see here, we use object detection to automatically determine the occupancy of a waiting room. Algorithm performance isn't ideal in the sample GIF, but optimization should help us better recognize individuals. Additionally, we will have regular audits of our open source code base coupled with on-site inspections to ensure that the data isn't being stored. Patient privacy is a large concern. Next. Hospitality also allows users feeling unwell to take a diagnostic test to find care they need. Users are asked a few questions about their symptoms and advised whether they should proceed to an ER, urgent care, or participate in telemedicine. Next. So here you should be able to see our form, which is, you can see that we ask for symptoms. And next, there are various pieces of advice that should help non-COVID and COVID patients safely get the care they need while minimizing their interactions with individuals at risk. Here are 3 of the results that you'll get from taking our quiz. Next.
Using the Google Maps API, the user will be able to see nearby clinics and their associated occupancies. Next. A more detailed layout can be seen that shows the distribution of patients and healthcare workers at the facility. Next. We will integrate our software with existing tracking platforms used by emergency departments. Once optimized, we will conduct beta tests at local hospitals and then send press releases to major organizations announcing the release deployment. Next. We are a team of 5 undergraduate students from across the US who are passionate about using our knowledge in health and technology to not only improve the user experience, but also help clinics unlock a digital front door to non-COVID patients. Thank you.
Thank you. The floor is open to the judges.
I had a quick question. Thank you. That was a great presentation. Excellent work on that. My question relates to, and you mentioned privacy concerns. So, you know, it's a significant barrier to try and get integrated into existing electronic health systems. So do you guys have any sort of mentorship along those lines?
Yeah, I can speak on that if my mic's working now. We spoke to our mentor in our Slack channel. I'm Jordan, by the way. And it was suggested that we use the NVIDIA Jetson card. It's sort of a small computer used for a lot of AI computer vision apps that is able to be integrated directly into security cameras. So the idea is it's in a location. We can add these systems we can simply integrate them into existing systems.
Any other comments from judges?
What would be the next steps? What else do you guys want to, where would you want to take this?
I think once we are able to fully develop the software and make sure it works with security camera real-time footage, we do want to integrate it with the existing tracking platforms that a lot of ERs use, and there's many different ones depending on the ERs. And another route that we're thinking of going is on-demand appointments, so that this could be applied also for elective procedures, which hospitals are losing a lot of money on. So if you're able to streamline a process for people to make appointments for elective procedures that may not be as urgent, so that they feel safe when they're coming in, that could be a huge new market for us.
Can I have a quick question on my side? It's part of the presentation. You're mentioning the recommendation made to consult. Did you get any of the mentors helping with some aspect of diagnostic and potential liabilities linked to diagnostics and need for validation?
Yes, during our first practice pitch, one of the mentors recommended that we have a disclaimer in our diagnostic. It is by no means a replacement for real medical advice, but we just think it is a quick tool that someone can go to if they are not sure if their issue is urgent enough to go to an ER, or whether they can resolve it through telemedicine so they don't have to actually go anywhere in person.
Okay, good, thank you.
All right, I just wanted to say that the 2 minutes questions are finished and we can go for the next thing.
All right, thanks, Team Hospitality.
Thank you.
Thank you.
Next up, we have Team A36 Triage Plus. And then up next after them will be team A18, Eon.
So once again, for the speakers, don't forget to click on the 3 points top right of my video, and you can see when the time is over.
Sorry, Mikhail, when will the time be over? Can you state that again?
So you have 3 minutes, right? I will put a yellow, a green card when you reach 1 minute, a yellow card when you reach 2, and red when it's over. So
Okay.
make sure you can pin me. You can click on my video and pin me.
Okay, for sure. Yeah, I see you.
Perfect. Good luck.
All right. Triage Plus at home. Home Heart Doctors Connect. Next, please. Our vision, we want to improve the way patients and practitioners connect and monitor health through delivered at-home medical devices and tests. Next, please. The need, so telemedicine has really proven itself during the COVID crisis. There's a 50 to 175x increase in the use in telemedicine, and medical devices is a growing industry. In 2018, the industry was over 400 billion, and in 2025, it'll be over 600 billion. Next, please. Currently on the market, there's a lot of medical devices, but they need wider adoption. Some of the friction to adoption is just the acquisition costs, logistics, and just lack of familiarity. Next, please. This will be our cardio kit. It includes lipid cholesterol kits, blood pressure monitors, pulse oximeters, and portable Bluetooth EKG, ECG monitors. Next, please. Our solution is a pre-packaged, ready-to-go, proven, FDA-approved rental model. So you can rent these devices on a monthly basis. The vitals and data will be provided to your practitioner. They're home delivered and you return them when you no longer need them. And they're sterilized after each user and ready to go. We're going to be working with existing manufacturers, proven manufacturers, and we're going to be working with insurance companies to provide this to patients. For the non-insured, this provides a better solution because of the lower costs due to the rental model. Next, please. So our solution allows us to connect those two growing industries of telemedicine and medical devices. And it helps us in the post-COVID environment to provide less contact for patients and more information to medical practitioners, bridging the gap between the two. Our team is Satish, whose background is in software and has worked in medical startups. Myself, I'm an IT project manager and I have experience in the healthcare industry. Ricardo, who is in consulting and data science, and Lashika, who works with medical device companies. Thank you.
Thank you, Triage Plus. The floor is open to judges.
Yeah, I think this is Santosh. I think it's an interesting concept. Have you guys given some thought into how and who is going to manage the devices themselves once you rent them? Like who will be delivering them, who will be collecting them, who will be cleaning them? How will they be configured once rented to actually work and transfer the data, etc.?
Satish, can you jump on that? Satish, our team member.
They need to raise their hand in order to be unmuted.
Yeah, he just raised his hand now.
Yep. Hi. Hi. Thanks for the question. So again, we would like to have a centralized model where we have a the warehouse model where we disinfect those and sterilize the devices with the medical grade cleanants. So and again, configure them into the zero state every time the device comes back to the warehouse. So that's a model, and that would be done by the Triage Plus backend operations.
Okay, so you guys will do it. Okay.
Yes, we guys will do it. Yes. And of course, these are all for dry devices. And if there are any wet devices, and obviously like lipid test, there will be one, use and throw. And obviously, the sanitization is only for dry devices like pulse oximeters, the new modern EKG monitors, and any of those new devices that are coming up and FDA approved. Thanks.
Hi guys, this is Ryan. That was a great presentation. Good job. So my question is on the rental stuff too. If you're renting the hardware, which is not really standard, you might think of a predicate healthcare company that's doing this to give you a little more credibility on this sort of commercialization front, if that makes sense.
Yes, it does. Yeah, that's a great point. And of course, right now, there is some model at the hospitals and enterprise grade level. We would like to bring the Rent the Runway, Amazon fashion style model for these healthcare devices for more wider adoption. That's the crux of the idea. Thank you. Thank you.
All right, thank you, Team Triage Plus. Great job with your rental device toolkit.
Thank you.
Next, we have Team A18, Team Eon, and then after them will be Team A34, Virtual Village.
Worried about a medical problem that works on you slowly, destroys your organs gradually, and kills you eventually? Start tracking your symptoms now and say goodbye to unprecedented complications with Eon, a medical alert bracelet that monitors, predicts, and prevents diabetic complications. Next. By 2040, 1 in 10 people are predicted to suffer from diabetes, and with the current trend, it's no surprise. Next. What's the relationship between COVID-19 and diabetes? None directly, but several life-threatening implications indirectly. Reduced checkups with GPs and lack of guidance to manage blood sugar since the onset of COVID-19 are a prelude. No real solution to manage symptoms in the dawn of post-lockdown era puts diabetic patients at a huge threat to life. Can we help diabetic patients while preventing recurrent hospital visits? Next. Well, here comes Eon, a fashionable bracelet. Eon helps to monitor vital signs, predict onset of infections, and prevent hospitalization. Next. Mind you, Eon is not a replacement of a medical practitioner, a diagnostic kit, or a medical prescription. What Eon is a means to interpret trends for patients and warn them of potential danger signs with a 3-framework solution. Next. How does Eon track your vitals? It offers interchangeable sensors that determine your A1C, heart rate, temperature, and oxygen. Next. The information is wirelessly transmitted to your phone, where you can visualize trends in a graph and get alerts on out-of-target values. A chatbot is then available to help you interpret this information and offer guidance on seeking care. Next. The Eon mobile design is easy to access, easy to operate, and has a user-friendly interface. Next. Our competition with what's currently on the market are devices that help you test your blood sugars and monitor your heart rate. Eon stands out by providing constructive feedback on your patterns, trends, let alone a chatbot that can help to notify your doctor. Next. The need of the hour is now. By working with the American Diabetes Association and partnering with Wearable Media, a company co-founded by our teammate Helen Teng, Eon can quickly go into production and be purchased directly by consumers. In the future, Eon hopes to help people across the world manage their health by supporting other chronic illnesses, and expand product capability. Next, today we have patients that are reliant on visits to the family doctor for information. But tomorrow, we envision a world where patients can confidently monitor, predict, and prevent health complications with a simple but powerful device on their wrist, Eon. Next. With a diverse team, we provide diverse solutions for the future. Thank you.
Thank you, Team Eon. The floor is open to judges.
Thanks so much. Just one quick question. Could you speak to the choice of an A1C to track there? Why did you guys specifically choose a hemoglobin A1C?
Yes, I would like one of my team members, Brooke, to cater to that. Brooke, can you unmute?
The reason I asked, just as a clinician, it's normally something we track like every 3 months, not something we necessarily continuously track.
You guys might consider tracking heart rate variability instead of just BPM.
Yeah, I'm here to answer that question.
Sorry, go ahead.
Yeah, so the thing is, which one of you asked about A1C? Okay, regardless of answer. So the thing is, we don't track A1C, we don't generally, like take A1Cs and, like specifically track them. We just, like use monitor continuous glucose levels, and then those would be on, on the time trends that is available in the app right now. And we'd be monitoring based on a graph where above 7%, it'll show you it's high. I mean, those peaks of continuous glucose monitoring will show you the trends are high. And if it's high, then the chatbot will actually intimate you to reach out to a doctor. So that's how we use it.
Yeah, but definitely especially for diabetic people, I mean, glucose, heart rate are very important because that's where you have the possibility to actually predict the most actually impactful event that will happen in the life of a diabetic. So the idea of integrating is very nice, and I think it's something that is extremely important to have a more holistic view of the patient, and I think it's a great thing you're bringing forward. Maybe need some tweaking on exactly what parameters you want to integrate in the end.
Okay, thank you, Team Eon. Great work.
Sorry, what was the number of that team again?
Team A18.
Okay, thank you.
Might I just recommend teams, whoever's presenting and anybody who might be answering questions, just all raise your hand to be unmuted at once so we can maximize your time. Thanks.
And for the next talk, don't hesitate to pin my video and just a reminder.
All right, so next up is Team A34, Virtual Village. And up next will be A19, SafeMed Connect.
They say it takes a village of doctors, doulas, family, and friends to go through pregnancy and raise a baby. But what happens when you're scared to see your care team and you're isolated from family and friends? Your village falls apart, and so does your emotional well-being. Next. This is what Peg is going through. Peg is a 25-year-old expecting mother in the US. She's scared and isolated and searching for a way to get support from other expecting and new moms in this new virtual environment. And she's far from alone. Next. Before this pandemic, depression was already a problem during and after pregnancy. Now, feelings of isolation and loneliness will only serve to worsen the problem. A socially distant pregnancy feels impossible. Next. This is why we're introducing Virtual Village. Virtual Village is a mobile app that offers women a support network by facilitating one-on-one connections and bringing together the fragmented maternal health ecosystem to give women the resources they need precisely when they need it. Here you can see a woman logs into the app with some basic information. Next slide. We then take a dating app style approach to connecting new and expecting mothers. Women can view each other's profiles, see what topics of conversation are of interest, and start conversations. Next. In addition, we aggregate existing and virtual resources that span the entire maternal health ecosystem, from virtual clinics to online parenting courses. We intend for referrals to these services to serve as the initial revenue stream. Our solution is a direct-to-consumer model. To boost customer acquisition, we also intend to partner with providers so they can recommend our app to expecting mothers, thereby positioning it as a trusted solution. Next slide. There is indeed a lot out there, but let me tell you what makes us different. Next slide. We performed a SWOT analysis, and we're confident that we bring an innovative and impactful solution to the maternal health ecosystem, especially during the COVID-19 crisis. We are the only solution facilitating one-on-one connections to combat isolation and loneliness, thereby mitigating risk of depression. We are also the only solution compiling the existing virtual solutions for expecting and new mothers into one single online directory. Our solution holds great potential for partnerships and data collection, and as an entirely digital solution, is easily scalable across customer segments. Next. We've outlined next steps aimed at implementing an MVP, and we're confident that we can quickly bring our app to the market. Next slide. As a diverse team who shares a passion for leveraging tech to advance maternal health during this crisis and beyond, we ask you to join us in investing in the emotional well-being of mothers. For many of us, our mothers are our rock, so let's be their village. Thank you.
Thank you, Virtual Village. The floor is open to judges.
Could you just go back to your competitive landscape slide for one more minute and talk through how you differentiate?
Sure. This one or the SWOT analysis? Oops. Sorry, I don't have control over the slides here.
Oh, yeah, sorry. Either the SWOT analysis or the one with all the vendors, that one,
Yeah.
the other vendor, yeah. It's a great idea. It's a very crowded space.
It is. It's a crowded and fragmented space. So we really hope to bring this into a directory to put these resources at a mother's fingertips. So instead of feeling overwhelmed and starting from scratch with Google, this will enable women to search with filters as an MVP, and hopefully for a longer term solution, we can leverage AI and machine learning to create more personalized recommendations with collaborative clustering algorithms as well.
Just you said fully digital, which means that you do not intend to have coaches or human beings moderating some interactions. It has to be fully digital.
Yes, so our intent in mapping out the landscape here is that we recognize that there are already people out there doing coaching, doing virtual clinics, parenting classes. So we didn't want to reinvent the wheel. We wanted to map out the landscape and say, where can we add value? So we think by aggregating these resources for parents, that is one great way to add value, and complementing that is facilitating this one-on-one connections through this dating app style approach. So again, that enables parents or new and expecting parents to forge connections and not feel alone in this new and virtual world that we're in.
Yeah, I think this is Santosh. I think it's definitely an important problem, but I think you also recognize that it's a crowded, fragmented market. I like your approach about aggregating, but maybe it'll help if you draw a parallel to some other similar offering that you know about, whether in the health space or some other space that has found wild success by aggregating existing offerings that are out there? Have you given it some thought, or have you seen some examples or drawn parallels to what else might be out there that whose path you may be able to follow?
Yes, so one strong parallel is with a startup called Patients Like Me, which connects people with similar conditions to provide a support network, and it takes a similar approach. So this is looking to work in parallel to that, to your point, and narrow in on a community that does not yet have a system like that in place.
Okay, if I may, just a little tip. There's a very big mental health problem in postpartum. Nobody wants to hear about it. Everybody wants to believe in the happy myth of becoming a parent. Women are in postpartum, for those affected, going through hell with no support. You may have an entry point.
Yes, thank you. We definitely recognize that.
Okay, great. Thank you, Team Virtual Village.
Thank you for your time.
All right, next up we have Team A19, SafeMed Connect, and after Team A6.
Okay. Hi, everyone. We are a diverse team from all over the world. Can I get started?
Yeah, I apologize. We need to get these slides in. So I'm going to skip you and we are going to go to Team A6. I apologize for the confusion. I am going to let Team A6 get ready and let the judges get ready for Team A6. So just a moment. Okay, Team 006, you can begin when you're ready.
Here is Conan O'Brien.
Hey everyone, can you hear me? Hello?
Yes, we can hear you.
Oh, perfect. Okay, sorry, I was unable to unmute. It wouldn't allow me to unmute. So we're good now. So I guess I'll just get started.
Yes,
Okay.
you can start when you're ready.
Thank you. Okay, so safety and accessibility during COVID-19. Accessibility is very important to me. My mother is deaf, and I noticed a lot of frustration when I took her to the doctor last week. She reads lips to communicate, and they were both wearing masks. So, that was definitely a frustrating thing that started me on the accessibility route during COVID-19. Today, though, we're focusing on visual impairment. Next. There are 8.4 million people in the US that have visual impairment. 60,000 of them can read Braille. We were lucky enough to meet Brendan Ward during our practice session. Brendan is visually impaired, and Brendan's visually impaired, and he uses Braille to navigate elevators, hallways. I'm sorry, I lost the.
Yes, sorry. We're going to pause you for just a moment. Everyone, hang tight. One moment. Just a couple more minutes. I apologize for the interruption, everybody.
For your information, the Google Slides is not responding right now. It's coming.
Yeah, take your time. All good. Really excited to present to you guys.
You're just getting your additional dose of adrenaline was the loss.
It's already kicked in.
So just an update after Team 006 goes, we will do Team SafeMed Connect. So SafeMed Connect, you can just start getting ready for being up next. Just a few more minutes. I apologize for the delay. Okay, we'll begin now. I'm just going to share my screen.
Great, thank you. So I can start?
Yes, you can restart, please, from the beginning.
All right, perfect, from the beginning, thank you. All right, so we are focusing on safety and accessibility during COVID-19. My mother is deaf, and I noticed that when I brought her to the doctor last week, She was having a hard time communicating because they were both wearing face masks. So accessibility is definitely top of mind. Today, though, we're focusing on visual impairment. Next. So there are 8.4 million people in the US that have a visual impairment. About 60,000 of them can read Braille. We were fortunate enough to meet Brendan Ward during our practice session, who's a mentor. He reads Braille in elevators, stairwells, hallways, subways, anywhere to basic in public places to help him navigate. Next. So how might we be able to help visually impaired people feel safe using Braille to help them navigate public spaces, and especially in hospitals and healthcare facilities? Next. So the problem, visually impaired people navigate the world using their other senses and most importantly, touch. Using Braille in elevators and hallways allows them to identify where they're going. So most elevators are made with metal, and the Braille in the elevators are made with either metal or hard plastic. And we know that COVID-19 lives on those for about 2 to 5 days, making a visually impaired person more susceptible and a higher risk of catching the virus. Next. Our solution is a UV light fixture that can be installed above the button bank in the elevator that will basically kill the germs on the Braille. UV light has been used extensively for over 40 years. It's already being used in hospitals. It's already used to disinfect drinking water, and it's been known to kill bacteria and viruses, including COVID-19. There's an added benefit here of universal design. It's actually for everyone. So not only does it kill the bacteria and the virus on the Braille, but also on the buttons. So anyone using the elevator is benefited by this light fixture. Next. This is what it looks like when it's in use. Next. So we did a quick competitive analysis. There is one company out there that is marketing a UV system for the whole elevator. The cost there is about $5,000 per elevator. There's another item out there called Push Safe. This is basically a stick that allows people to push the buttons without touching them, but this doesn't help visually impaired people. Next. So we did a quick cost analysis for all of the items: the Arduino LilyPad, which is the processor, the sensor, the converter or lithium battery, the UV light strip, and the housing could all come in at around under about $50 per unit, which makes this very cost effective. Next. So how do we market this? Our philosophy is all about inclusivity, accessibility, and autonomy. There's a focus on B2B with the B2C marketing. Our main customers are going to be hospitals and clinics. We're going to be doing brand awareness, print media, and television, and targeted awareness with social, email, and PR. Next. And who can we partner with? There's a lot of organizations that we'd love to work with: American Council for the Blind, American Foundation for the Blind, Blind Veterans, to name a few. Next. And thank you for Team 006.
Thanks, Team 006, on your presentation on innovations for people who are disabled. I want to open up the floors to the judges.
Hi guys, this is Ryan. That was great, thank you. I would encourage you guys to figure out who the buyer is for this. Elevator manufacturers probably are those people, and approach them and see how they tackle buying hardware for these elevators. And as far as the pricing, even if your cost of goods is low, you can probably demand more of a premium price for it, since it's only one per elevator. But that was nicely done.
Thank you.
I agree. I think this was terrific. Thanks for tackling this, identifying and trying to tackle this very important problem. My question, I think the application of UV is interesting. And I see that you are stating that UV is being used for disinfecting for COVID. And I know that it is, but I recall also reading an article where they said essentially it was a BBC article that said there's only one kind of UV that can kill COVID, and that can be extremely harmful for human beings. So I don't know what research you've done. Would love to learn a little bit more about So what happens to the light when someone's hand is sort of going to press those buttons? Is that okay
Great.
or not?
Yeah, great question. The light would only turn on when the elevator had nobody in it. So that's the reason for the motion sensor. So when the elevator is in idle, or when the elevator is traveling between floors when nobody is in it, that's when the light would come on. The minute somebody enters the elevator, it would shut off. Or the doors open, it would shut off. So we would absolutely want to mitigate any risk of having UV when somebody's in the elevator. We do not want that. But we want it when there's nobody in the elevator and between floors and when the elevator's in idle.
Interesting. So let's say there's 4 people that need to use the elevator at the same time and each have a different button to press.
Yeah.
I'm guessing that you would still allow the light to work in between different fingers going over the buttons. But what needs to be the time of exposure of the button to the light for it to...
Yeah, good question. We do not want it to work when anyone is in the elevator. It would not work when anyone's in the elevator. Only during idle times and when there's nobody in the elevator. We don't want to risk exposure to anybody to harmful UV. And I know there's UV applications being used at nail salons and things like that, but we don't want anybody exposed to it and under any circumstances. It would only be in idle positions.
Thanks.
All right, great. Thank you, Team 006. So we are going to go to the team that we skipped over. Team A19, SafeMed Connect.
Yeah.
And then.
So very quick, yeah, don't hesitate to pin me. I mean, the 2 teams were a little bit over, so make sure you finish after 3 minutes.
Yeah, sure. Thank you.
And after Team SafeMed Connect will be Team 38, Patient Connect. Was there a question?
Yeah, let's go.
Okay, you can begin.
Hi, everyone. We are a diverse team from all over the world with multidisciplinary expertise coming together to create SafeMed Connect as the solution for patients affected by postponed surgeries. Next, surgeries are postponed across the next world as a result of the pandemic. For instance, where I'm from in the UK, 50% of the cancer surgeries were cancelled during the pandemic peak as of 15 May 2020. How does this affect the patients? For instance, in Birmingham, a cancer patient's surgery was cancelled 2 days prior. When she expressed concerns over turning terminally ill, the doctor did not have an answer. She was very frightened. With SafeMed Connect, we want to help patients like her by providing access to hospitals that are past the pandemic peak and helping them get more patients and make money again. Still, patients are not going to the hospital. Why? Next. Due to fear of contracting the virus and the lack of available hospitals for non-COVID surgeries. How do we fix this? By redirecting patients towards available hospitals and providing a tailored experience to manage patient anxiety. We will achieve this using SafeMed Connect, a platform that integrates 3 key factors: virtual consultation, hospital choice, and transport, to enhance surgery experience in this new COVID world. Next, what does this mean for the patient? What does this mean for the patient from Birmingham? The patient gets to identify the predicted COVID status through a machine learning approach that uses questionnaires in combination with just coughing into the phone. Depending on the predicted COVID status, the patient is given the option to proceed with surgery scheduling or not. Following this, the patient can get a second opinion and reassurance on if they indeed need a surgery through video conferencing. Once the patient is flagged for surgery, then the next is how will the patient choose the hospital? We enable the patient to make an informed decision by providing ranking of hospitals in a region based on a number of parameter filters, like number of COVID patients in the hospital, availability of operation theaters for non-COVID patients, and symptom status of attending doctor. SafeMed even allows you to rank the hospitals based on multiple parameters like insurance availability to provide a tailor-made experience to the patient. Now, how do I get to the hospital? SafeMed Connect provides transport in the form of Google Maps and integrated Uber, and also our favorite, Community Chaperone. Introducing Community Chaperone, it enables the patient's community to register with our platform and provide transit to and from the hospital through possible collaboration with National Bed Trans, an agency that funds non-emergency patient trips. This is especially for you folks out there without insurance cover for transport. All in all, equipped with a chat box to guide you, MedSafe Connect provides a tailored experience for anxious patients who need a hospital for surgery. Here's the market model for consideration, highlighting revenue streams and cost structure. Having said this, we are going to use this market model to overcome challenges such as getting hospitals on board, ensuring collaboration with medical record sharing platforms, and designing a geographical area for introduction as an implementation of the platform. Thank you.
Okay, thank you, Team SafeMed Connect. The floor is open to judges.
So this is Ryan. Oh, go ahead.
There was just a very simple question, which is why focusing on the cancer patients? There are a lot of other scheduled procedures, especially in ophthalmology, that have been canceled, and then where the people already are afraid to come back. So why the specific focus on cancer? Because it may not be always where the people are the most neglected, I would say.
That's a very good question. The focus is the patients who have postponed surgeries and not specifically cancer. The cancer was chosen for a very nice following the journey of the app through the patient from Birmingham as an example. So the focus crowd is the patients with postponed surgeries in general.
So hi guys, this is Ryan. So my feedback is I think it's a great idea. There's a lot of stuff here to figure out. You might simplify and just do like 2 of the 3 things. The telemedicine consult in the front end, then the hospital, then the transport is kind of a lot. And also for identifying a hospital, people usually go to their PCP in whatever hospital they are at anyway. So you might think about that as an entry point. So the idea is to find the demand and supply situation. Here, the hospitals are going to benefit from patients being redirected to them. So the hospitals have an incentive to actually share the data, such as the COVID patient status, whether the operation theater staff are being tested or not. And these details will be shared with the patient through those parameters and help them make an informed decision. And even things like the number of operation theater beds that will be available is one of the features that we've included. So yeah.
Okay, great. Thank you, Team SafeMed Connect. Next up.
And that Team 18, SafeMed Connect?
Yeah.
Yep.
19.
Great, thanks. 18 or 19?
19.
19, thank you.
Yep, Team A19, SafeMed Connect. That's who we just saw. And next up will be Team Patient Connect, Team 38. And after Team 38 will be Team 21, Mask Design.
Hi, everyone. How's my volume?
It's good. You can
Okay.
begin.
Welcome all. We are Patient Connect. We're a way for patients to find care and stay safe. Next slide. So we want to start off with a bit of a personal story about an elderly neighbor of mine. He had asthma as well as a pneumonia infection, but feared going to the hospital over the risk of getting COVID-19. When he went to seek out care, he was actually denied by 7 different hospitals who were only treating COVID patients before being finally admitted to the 8th hospital. But by then, his condition had deteriorated and it was too late. Ultimately, he passed away. But if only he knew which hospitals would accept him before leaving home, he'd still be with us today. Next. This is actually a frustration that's concurrent throughout the patient spectrum, especially those looking for acute care. One, we see that patients are actually fearful, with only 36% feeling less comfortable visiting their providers. Two, these patients are neglecting to seek care, as we've seen 50% fewer emergency room visits in recent months. And third, we've seen that patients are actually dying, with a 1.5 times increase in fatal at-home cardiac arrests. What these three statistics highlight are that non-COVID-19 patients don't know which hospitals are safe for them to seek care at. Next. And that's actually where we hop in. We're Patient Connect. We're an online tool to help patients make informed decisions, find the right hospital, and connect them to their urgent care providers. Next, please. We'll start off by walking you through the patient journey using our application. It starts with our patient Mo, who's going to input his relevant data into the Patient Connect interface. Using that, as well as hospital logistics and regional demographics, our machine learning algorithm is going to recommend a hospital for Mo to visit. And once Mo has confirmed his recommendation, he's going to go seek his positive healthcare experience at that hospital. Next, please. We also brought a bit of a demo interface, so we're going to look at these three panels. In the first panel, we're looking at patient inputs, where we display really easy and intuitive design, making this as accessible to patients as possible. In the second, our algorithm will provide one really strong recommendation, but also different alternatives if our patient feels those are more necessary. And in our third panel, for hospital details, we're going to list different specific parameters, things such as average wait time, specialty units, COVID incidents, and travel distance, so that they can continue to research and feel confident in the product. Next. And here we are with our next steps. So we're going to go through 4 phases, one being the build phase. And in this phase, we're going to acquire the greatest amount of cost in acquiring different amounts of data, but we're going to aggregate that data from hospitals and other databases, and then engage with potential partners to expand our operations. Next, we're going to pilot our program in a defined geography and refine the algorithm itself with new information. Next, we'll launch and expand globally after beta testing. And then in a post-COVID world, we plan on making Patient Connect ubiquitous within the healthcare industries. And lastly, on this last slide, we are the wonderful faces that have brought you Patient Connect. We're a global, diverse, and driven team with experience across medicine, engineering, data science, and business. So please help us in helping patients find care and staying safe. Thank you.
Thank you, Team Patient Connect. The floor is open to judges.
Great presentation. Again, tragic story that you started with. Can you detail a bit more how you plan to source the data, particularly from providers? Some of the data types that you outline aren't necessarily going to be readily available to inform the platform.
So we plan on using the different KPIs from hospitals as we have them available, but that's also going to be paired with like a predictive technology, knowing that different hospitals will make it known what beds, what size, and what patient traffic they typically experience. But once we pair that with the other 2 categories of data, like the patient-specific factors, as well as the regional demographics that most governments, as of right now, are collecting, we should be able to provide a predictive as well as a certain value for these parameters and these recommendations.
Can you guys talk about how you think you'll get the data? That can be tricky to do from most hospitals.
Sure, no problem. Okay, so in getting the hospital data, it looks like what we're planning to do is partnering with different hospitals at first, as well as endorsing or finding a way to partner or get endorsements from the government so that we can more readily access their data. I think once we bring it to the hospital or the urgent care centers, once they see the benefits and the positives, they'll be more than happy to help us on the data end of things, being that this will increase patient access as well as boost and support their operations and efficiency.
I would suggest that, in order to further shape your idea, you discuss with US integrated providers like Kaiser, people like that, and probably help you to also talk about this data sourcing and about the potential values they could see as an integrated provider.
And to add one more data set that we have, we talked with our mentors from InterSystems, and they actually have data sets about COVID-19 patients, which we can use. And they also mentioned that they have hospitals per city, public data, and per state, which we could potentially use.
So I think that point that you raised right there, you should put in your pitch. That sort of strengthens the sort of how we get it done portion of it. That's pretty powerful.
And lastly, we had some unmuting problems here, so apologies for that. Lastly, one thing we're looking into is that we assume that all of this data is being tracked on a per hospital basis within each hospital in various forms. Really, what would have to be enabled for us to be drawing on this data is an access to the APIs of the different hospitals, assuming larger clinicians, to provide access to this data. So if we're looking at things like availability of beds at a certain time, or the wait times in the ER at a certain point in time, for large hospitals, this may be tracked on an individual basis, but it's not being aggregated into one platform.
Okay, great. Thank you, Team Patient Connect.
Thank you.
All right, next up we have Team A20, One Mask Design, and after we have Team A50, Medibot. Okay, you may begin.
Currently only have one person raising their hand. Is anyone else supposed to be speaking who I haven't been able to unmute?
Hello? Hello?
Yes. Hi,
Hello?
Team One Mask. The One
Yes.
Mask, you can begin.
Reusable, comfortable, and smart face mask. Why wait? My name is Fidal, and my team and I are on a mission to design a great face mask in the COVID-19 era that is reusable, comfortable, and smart. Next. When lockdown finishes, some non-COVID patients may fear that it might be not safe to seek preventive medical care, and thus they will delay their checkup. One way we can reshift our attention is by ensuring safe environments to provide care in new surge of patients seeking non-COVID related health care. One recommendation is to wear face masks. COVID spread is greatest among the lower socioeconomic status, including African Americans, who also happens to have a much higher rate of death due to cardiovascular disease. Next. We looked into possible reasons why the currently available masks are either not working or not working for a lot of people. This is a summary of our findings. It is clear from this that feeling suffocated stands out as the most common issue, followed by communication difficulty for why compliance with masks are an issue in most preferring a reusable mask. Next. So these are some of the choices that are available right now. Next. We have redesigned one of the most protective masks currently in the market. These are the new dark beta half-face mask that is reusable, comfortable, and smart. This redesign would include a concept to upgrade it every few years with the possibility to expand it to other populations. Next. A face mask is one of the most proven ways to prevent COVID spread. If it is inexpensive and user-friendly, then there is a higher possibility of those of the lower SES community will wear them. The redesign of the Darth Vader face mask provides the greatest protection in place of the N95, which is recommended for healthcare providers. The potential limitation of the Darth Vader half mask is the large filter size cartridges, which will overcome by design our prototype to a smaller, less bulky feature and potentially for further improvement. Next. So we went and asked people about features they would prefer in a mask if we could make it into a smart device. The demographic survey indicated that people want a comfortable, reliable, and practical go-to mask, which is a value prop for the one mask, which we aim to be the standard when people invest in masks for daily usage. As its filters, which are similar to the N95, will be smaller, the cost for producing it will be within the cost-effective budget that the consumer will purchase once and have it for life. My team consists of a diverse group of experts who are deeply committed to ensuring the highest quality of product. Next. So what you have been, we have seen is a growing trend of fear developing in the U.S. A fear among the most vulnerable population at risk who are not truly receiving the preventive care they need when the lockdown ends. Our redesigned concept of a Darth Vader face mask focusing on its reusability.
Thank you, Team One Mask Design. The pitch time is up and the floor is open to judges.
Can you speak to me into your projected price point?
So we haven't analyzed the price for this yet. It's still a concept. But if it were to be made in a budget saving manner, we can sell it and have it in the market so that people who are the most vulnerable will be able to access it. And in the event the budget is outside of what it costs, we would approach the federal government to subsidize the use of it because it will keep the costs low if the admissions for not wearing masks and the risk for it are up.
So you highlight that it needs to be breathable and reusable. So you sort of underscore the needs, but how would you accomplish those things?
So right now, the Darth Vader was for that these type of masks that are available there have the feature where you can breathe through it. It's not suffocating type of mask like the N95, which are completely sealed and very difficult to wear for a lengthy period of time. These ones that are the Darth Vader type, you can breathe through them and you can be worn for a lengthy period of time.
But those already exist. So, I can get one of those at the hardware store. So what is your proposed improvement to that?
One of the other group members can mention something.
Yeah, so a couple of things that we can improve is maybe exploring things to drive down the cost of the mask itself. So when it comes to these Darth Vader style masks, they're expensive usually because they use very high grade filters that are used for very industrial type applications. But we could explore the use of some homemade materials for the filters. That could be one. And two, there could be also a potential of trying to incorporate some electronics into it, say for better communication, where you could have, say, a microphone, or you could have some sensors that can monitor some vital signs like breathing or temperature of the patient or the person who might be wearing it in order to kind of update them on an app or something on what their vital signs are.
All right.
This is done with the view that they're going to be wearing the mask for long periods of time.
Great. Thanks, Team One Mask. Up next, we have Team A50, MediBlocks. And after them is Team A08, Co-Ponder.
And a reminder again, once before you start, to really look at the time and finish around 3 minutes, please.
All right, Medi-Blocks, you can begin.
Hi, can you hear me?
Yes.
Okay, great. Hello, world. I would like to introduce Virtual Vitals, a project by Team Medi-Blocks. We are living in an incredibly strange and challenging time. The need for improved doctor-patient relationships are becoming increasingly apparent. Global video telemedicine market has been forecasted to reach 3.5 billion by 2027, and these are pre-COVID stats. We're hearing things from the healthcare community saying things like, pre-COVID, we were seeing about 800 to 1,000 video visits a month. Now we're seeing between 3,000, 4,000 visits a month, and it's exponential. Doctors are saying things like, our patients have been monitoring some of their vitals. They just need a gentle reminder to do it, to document it, and to communicate it. Slide, please. We heard you. We understand. Vitals are vital. We have identified the problem as a lack of affordable medical devices to monitor patients' vitals to support telehealth consultations in a practical way. We believe a potential solution can be a modular design device, which allows a plug-and-play mechanism enabling patient vitals to be monitored and communicated to healthcare practitioners. This could be supported by a dashboard with cross-platform interoperability. Slide, please. Our proposed technology solution can be seen on the slide. I don't want to get into specific technical details. I would just like to give you an indication of the technology systems and how they would interact between the users. Slide, please. The digital touchpoints would include an app and will be extended into integrations with authorized HISP telehealth software applications. The app would be pretty simple, a sign-up sheet, choose what vitals would be tracked, and scheduling when you would like your check-ins. Our motto is check in before your checkup. Next slide, please. These would be some simple wireframes of how the different dashboards could be represented. Slide, please. Our value proposition is to address the gap between patient and doctors for vitals data flow in remote settings by providing affordable and modular solutions which can be scaled based on the needs of the customer or user's unique context and requirements. Our key partners would be funders and sponsors, technology service providers, and even organizations like MIT's Little Devices Lab. Our customers
Thank you, Team Medi-Blocks.
Thank you very much for your time.
Okay, the floor is open to judges.
What's your roadmap for next steps? I don't think we can hear.
Oh, sorry. So for our next steps, with the guidance of some of our mentors and key partners, we would like to continue working and developing the device. Ideally, we would like to accelerate this R&D stage so we can commercialize. So we'd like to get prototyping, testing as a pilot project and leverage that pilot project to do some more improvements on user design and hopefully take it to market from there.
Could you speak a bit more to the competitive landscape for this space?
So the competitive landscape is very interesting at this space. On the one side, you are seeing a lot of smart watches are basically moving a lot into the monitoring space of health data. The mHealth, mobile health ecosystems are developing quite rapidly. So there are a lot of different devices that are being developed. What makes this slightly a comparative advantage, I would say, over here, is the fact that we are trying to focus on creating a core skeleton at which different components and auxiliary components can be attached to. So it can be upgraded according to affordability and user requirements. With regards to our other competitors, we'd like to look at it in a more collaborative sense. And if they are collecting data, why not leverage off that data that's already been collected?
Okay, great. Thank you for your response, Team MetaBlocks.
Thank you.
Okay, next up we have Team A08 Co-Ponder, and next up will be Team A02 OptiFlow. Team Co-Ponder, you can begin.
Is anyone besides Riyadh planning to sprint?
Oh, sorry, I didn't hear that.
Okay,
Can you please repeat the question?
Oh, sorry. Nobody else has raised their hand. So if someone from this team could raise their hand, I can unmute you.
Oh, sorry, I must put my
Sorry.
hand down. I was in the last presentation. So.
Yeah, but we need the next team to raise theirs. Thanks.
Team Co-Ponder, are you there? Please raise your hand if you are. Okay, we're gonna move on and go to the next team, which is Team A02 OptiFlow. So I'll give you guys a minute to get prepared since it's a little bit instant. So we'll start in a minute, let the judges change their form to Team A02 OptiFlow.
Hey guys, am I audible?
Yes. You can begin when you're ready.
Okay. I'm ready. All right. Hey everyone, we are Team OptiFlow. We provide an optimization platform that makes healthcare simple, fast, integrated, and thus mitigating exposure to COVID-19. Next. This is Carl, and he has diabetes. Carl used to visit the doctor every month, but had canceled his last 2 appointments because of the pandemic. He's still worried about his diabetes, but does not want to spend hours at the hospital potentially exposing himself to the virus. Carl is one of the 133 million people with chronic diseases in the United States. Before this pandemic, 61% of all hospital visits were for chronic conditions and routine care. Only 1 out of 5 of these visits are crucial and require health-saving medical intervention. Next. Like Carl, there are a lot of patients with chronic conditions who are now hesitant to visit their physicians regularly, potentially risking their health. So how can we optimize care for patients with chronic illnesses during this pandemic? Next. If you can personalize and optimize chronic care management, avoiding hospitalization and serious complications, the healthcare system can improve the quality of life for patients and greatly reduce the ballooning cost burden that we all share. Through our platform, we offer proactive provider-initiated consultations, optimized hospital visits with reduced wait times, and follow-up care that is personalized and driven by reliable predictive analytics. This will decrease unnecessary trips to the doctor and reduce the density in hospitals, minimizing the likelihood of non-COVID patients contracting the virus. Next. OptiFlow can be integrated seamlessly with existing hospital workflows. The doctor portal can be used to tailor the follow-up forms with specific relevance to individual patient needs. The updates dashboard shown on the right can be used for real-time monitoring of the patient status and to proactively initiate a consult as need be. Next. OptiFlow facilitates dynamic appointment scheduling, including consultations with specialists. This platform allows the patients to fill out necessary forms before the visit, significantly reducing wait times between consultations, examinations, imaging, testing, etc. Next. Another major area of impact for OptiFlow is in providing personalized follow-ups with periodic structured symptom check questionnaires and real-time monitoring of vitals using data from wearables and connected testing devices. If the patient's condition worsens, family members and trusted contacts can be alerted in addition to the healthcare provider so that proactive action and patient support can be initiated immediately. Next. In short, we provide individualized care driven by predictive analytics, optimized access to healthcare with only necessary visits and reduced wait times, as well as a revolutionary new approach to care where providers have the ability to proactively initiate appointments. Through this integrated approach, our solution will improve the standard of care for non-COVID-19 patients, as well as battle the pandemic. And I think moving forward, even post-pandemic, this is going to be a really useful tool for the general public and hospitals to use. Next. This is our team, professionally diverse, globally located, yet with a common goal, better healthcare for patients in this COVID-19 era. Thank you, and we're open for questions.
Thank you, Team OptiFlow. The floor is open to judges.
Great presentation. Go ahead, sorry.
So would you qualify this as more a solution for healthcare providers or for patients? You know, who is supposed to be the primary customer for you?
We're looking at this as an integrated approach because right now the system is quite fragmented where you have different hospitals and different patients using different platforms. And we aim to integrate this so that you can think of it as a patient login and a doctor login. So it would look differently for whether it's a patient or the care provider, but the functionality is integrated so that everything happens on the same platform, on the same app.
That's helpful. Great presentation. Can you speak a little bit more in depth about the competitive landscape and differentiation, especially given that many EHRs both have their kind of digital front door and chronic care management modules?
That's a great question. I'd like to see if anybody from my team would like to jump in.
Regarding that, our main point of differentiation is that we are integrating the whole care process involved. And one important aspect that we are newly introducing is the physician initiation of the consult rather than waiting for the patient to seek out healthcare. Also, we are introducing a feature in the platform where the physician structures a specific questionnaire that the patient would be expected to fill out as per specified intervals, say in interval of 2 days or 2 weeks, depending on the patient's status, which would give an indication regarding the patient status, and this would be communicated to the provider, thereby causing the healthcare visit to be earlier if necessary, or if there could be a wait, even that could be addressed.
Yeah, so we hope that what's unique about our solution is that this allows doctors to catch complications in time to prevent unnecessary hospitalizations later on.
Have you guys thought about how this would be regulated by the FDA if you're guiding clinical care?
We'd like to stress that the clinical care is still going to be in the hands of the provider. So we aren't trying to intervene there and replace what is existing today. We just want to equip the healthcare providers with better tools and with better data, because right now it's more symptom driven when you think about remote telemedicine. So providing a little more data that the provider can look at and make decisions based off of, let's say, data from vital monitoring that they would have if the patient actually came in. So I believe that's where the solution lies.
Okay, great. Thank you, Team OptiFlow.
Thank you.
Next up, we have Team A03. And after we have Team A011, Alpha 11.
Am I coming through okay?
Yes.
And the video is working? I can't seem this. Okay, there we go. Okay, can we go ahead and get started?
Yes, you can begin. Thank you.
Beautiful. 100, 75, 50. I want you to commit these numbers to memory. Next. 100. Here in the US, we spend 100% more per capita on healthcare costs, over $12,000 USD annually, than the average of all other OECD countries. 75. 75% of the spending goes towards management of chronic diseases, most of which are in large part preventable. 50. 50% of US physicians experience burnout, with documentation and insurance billing being the #1 causes. These may seem like disparate issues, but all three of them stem from the way that care is both financed and delivered in this country. Next. In other words, they stem from a fundamentally broken health insurance system. Once we realize this, we see that in fact the only way to proceed and successfully treat non-COVID patients is to redesign health insurance from the bottom up. Next. 50, 75, 100. 50. Our solution is an insurance plan that is 50% of the cost, with a flat annual fee between $5,000 and $6,000, roughly what most employers currently pay for employee health benefits. But importantly, there are no other costs, no copays, no premiums, no deductibles. Employees themselves pay nothing out of pocket. 75. That's 75% that is normally spent on chronic disease management. We're spending it on virtual, preventive, and collaborative care, reducing both our overhead and downstream healthcare costs. Through our app, our members can communicate effortlessly via video and chat with their own dedicated care team, consisting of a family medicine physician, a behavioral health specialist, and a health coach. For all other needs that might necessitate an in-person visit, our members can easily schedule right through the same app with our in-network partners. 100. We aim for 100% physician satisfaction. Our payment model frees physicians to do what they love, focusing on patient care, not paperwork. Next. Current and future steps. First, user research and product development. We will continue conducting user research with relevant stakeholders and building out our platform, paying special attention to issues of usability, privacy, and security. Second, securing funds. We've identified 2 potential underwriting partners and plan to leverage our extensive networks for connections to angels, VCs, and potential customers. Third, building our network. We've identified a number of potential network partners and have initiated discussions with One Health System, Christ Health, the largest health system in Cincinnati. Our team member Satya serves as a cardiologist and director of care delivery innovation. Next. Speaking of our team, our strength is in our diversity, combining clinical, technical, and entrepreneurial expertise. Next. 50, 75, 100. 50% of the cost, redeploying 75% of resources towards preventive care, aiming for 100% physician satisfaction. We're a new kind of insurance plan. Your employer pays a flat, affordable fee, you pay nothing out of pocket. We deliver virtual preventive care straight to you and partner with hospitals and clinics to cover your in-person needs if and when they arise. Thank you.
Thank you, Team 3. The floor is open to judges.
Thoughtful question. Can you speak a bit more to the economics of how you would make this insurance plan work? I don't know if we
Sorry
can.
about that. I believe I was muted. Sure. So the economics. So we're primarily looking at a direct primary care inspired model. So instead of physicians rather being paid, kind of a fee for service model, they're paid on a monthly recurring basis for the number of patients that they're caring for. So say for a typical DPC practice, say a physician will see maybe 500 patients as opposed to the normal caseload that they would see in a traditional like hospital or clinic setting. They can spend more time with each of those patients, and the economics show that physicians earn more under a DPC type model because they're taking home a larger percentage of the revenue. So.
Any other comments from the judges?
A very quick one. How easy or difficult do you think it's going to be to embark, providers like clinic and hospitals, so you don't have to go to building the brick and mortar aspect of care?
Sure. Yeah, so that's one of the I think advantages of our model is that by focusing primarily on kind of virtual collaborative care, we can avoid those brick and mortar costs, but certainly some aspects of care will need to be delivered in person. That's, as you mentioned, where kind of the health system partners come in. So firstly, one of our leading kind of potential partners would be Christ Health in Cincinnati, Ohio. One of our team members, Satya, is a Penn-trained physician and Wharton MBA. He currently leads healthcare delivery innovation at that system. We've also, through this competition, connected with one of the fellow mentors from Northwell Health. We have connections to a few different health systems, both in the Midwest and on the East Coast. So we're exploring a number of avenues. And it seems like, we'll have a relatively, I don't want to say easy, but, there's definitely a path forward. And, one of the things that we're especially paying attention to is, given especially the COVID pandemic, hospitals rather have, seen a huge drop in their revenue, of course. And so what we can promise is that, with a health system partner for our client base, we will be able to send them all of the procedural care so they can hopefully start to rebuild that revenue base.
Okay, thank you.
Great. Thank you, Team 3. Great job.
Thank you.
Thank you.
All right. Up next, we have Team A11, Alpha 11. And after will be A24, Co-Opal.
Hi, can you hear me?
Yes.
Excellent. Okay. In this pandemic, more than ever, chronic patients around the world are stuck at home and can't access their inpatient care. We want to help. We are Alerter and we provide insight for your hindsight. Next. More than 1 in 2 people in the United States live with a chronic condition. These diseases cause 251 million deaths globally every year and cost the equivalent of the entire annual budget of the United States. Next. Every day, chronically ill patients face three major questions. What is my current health status? Why leave home and face crowds? And when do I need to visit the emergency room? And COVID has only worsened their condition. We help patients answer these questions. Next. We will build an app that compiles objective data from wearable devices on chronically ill patients at home. Since every chronic disease is different, we will customize the set of wearables and parameters for each disease. Along each stage of our process, we take inputs and feedback from clinicians, since they are integral to our success. Our predictive model identifies when a patient will need to go to the emergency department using established thresholds and guidelines. We then set the patient's status as stable, needs evaluation, and emergency. Next slide, please. If a patient is stable, their data and input will be stored for their monthly evaluation. If a patient is in need of evaluation, they will be able to contact their physician through our app. And if the patient is in an emergency, the app will alert the patient's family and the emergency department and send the patient's latest data. Next slide, please. As an example, we built a prototype for COPD patients. Health metrics like pulse oximetry and breathing rate from wearables are displayed in real time. Patients can input their symptoms in a standard survey. Patients may communicate with medical chatbots in a HIPAA-compliant way, and if necessary, a healthcare professional in real time. Next. We are building the only app that combines real-time data with a predictive system while also managing both emergency and routine medical responses. Next slide, please. This hackathon has allowed us to partner with luminary resources such as Johns Hopkins Medicine to build a standard predictive model. We will integrate Alerter with wearables that are appropriate for each chronic condition, starting with COPD, and interview hospital systems, insurance companies, and patients to determine feasibility. Next slide, please. And here's the team that will get it done. Next. We're Alerter, and we provide insight for your hindsight. Thank you very much.
Thanks, Team Alpha 11. The floor is open to judges.
Could you explain your competitive landscape slide again one more time for me?
Yeah, if I could have Juliana or Esther, please answer this.
Okay, so hi, we compiled some apps that are able to work to predict symptoms and predict diseases, but ours is the only one that works with real-time data to predict exacerbation episodes for chronic diseases, and it starts the emergency chain. So it contacts the patient's health contact, emergency contacts, and it also, if there is not a response in 2 minutes, it also contacts the emergency facility, so we can provide help for the patient.
Thank you.
So very, very nice presentation and nice work. On the device side, how open or directive do you think you need to be for this to work in terms of choosing the device, what kind of device, and how many can you allow to be integrated?
I had a problem being muted there. So your question was, how do we decide which wearables to integrate with? Okay, so that would be determined with the help of medical experts based on the chronic disease that we're trying to help. So, for example, with COPD, we have spoken with an expert at Johns Hopkins, and he recommended a few different wearables that we could look at. So I think that needs to be determined on a case-by-case basis.
Okay, thank you, team.
Thank you.
Thank you.
Next, we have team A24, Co-Opel. And after that, we have team A47 of the college.
Hello, can you hear me?
Yes.
Okay, let's get started. Do you know that diabetics are 3 times more likely to die from COVID-19? With improved treatment and better blood sugar levels, their mortality can be reduced by 76%. We will show you how. Next. 34 million people in the US are diabetic. Up to 80% of these patients don't follow their treatment plans. As a result, almost $25 billion are wasted, and that's just medication non-adherence. This doesn't even include complications and secondary diseases. Whether the patient complies with the prescribed treatment or not is determined by many factors, but there are 3 components that stand out: communication, partnership, and loneliness. Next. Yes, you have heard correctly. There is scientific evidence that lonely diabetics are worse at following the treatment. As health professionals with many years of clinical experience, we have been able to build a different perspective. Next. We know that a successful treatment is all about support. A patient's most valuable support is their partner, but who supports them? There are hundreds of applications supporting the patient, but none is designed to assist the support, and this is what makes us unique. Next. We present to you Co-Opel, a toolbox that empowers and enhances patient support. It contains several tools. A question box is the ideal solution for concerned users to express their concerns and get professional assistance. Next. By creating a community with groups that actually care for each other, we ensure that nobody feels left alone with their fears and challenges. Interact with people who are in the same boat as you and support yourself with reminders of appointments and taking medication. Next. Partner promote communication and partnership. If you're stronger together, you can stand stronger against the disease. Next. There are more than 27 million diabetic patients in the US who don't follow the recommended treatment. Following existing data on hazard ratios regarding partnership, we estimate we can improve the treatment success of up to 55% of the patients by targeting their support group. Next. Our business model consists of 2 areas. On the one hand, we want to offer a subscription that allows a 24/7 availability to users. We also expect to partner with companies and insurance companies. Next. We implement our solution in 5 steps. First, we prototype and test the tool in subgroups of patients. After a successful launch, we want to take it even further. We see incredible potential in our tool and other chronic diseases like Alzheimer's disease and cancer. Next. The potential of supporters as a resource is almost unlimited. Our tool can be scaled up and down to fit its users and community. Next. In the end, diabetes is not a one-player game. We are all part of the same team. Want to join us? Next. Thank you for your attention, and always keep in mind, sometimes all you need is love.
Thank you, team Co-Opel. The floor is open to the judges.
I know it's a recurring question we ask, but can you speak a little bit more to the competitive landscape and differentiation? There's a variety of other services in this space.
Yes, so we know that there's a lot of data on non-compliance, especially in diabetes, which is a very big field, and obviously there's a lot of patients that are affected of this disease, and there's a lot of applications that help with non-compliance, such as reminders for doctor's appointments, management of the disease. But as far as we know, there are no systems, applications that directly target the support system, the partner of the patient, as somebody new that we can then take into the healthcare team as we see it, where we include their support in the support that we can give the patient.
Yeah, I think the answer to this question
is right away in the slide 2 because you don't see it, but in this slide we mentioned that and the support, the two people hugging, the 4, I think, this the differentiation is supporting your support. We're not focused on the patient. We're focused on the support. So starting with the one you love, that's why our name is couple, because we are focused on the couples that are with diabetes, one of them or the two of them. So this is our differentiation, but maybe the slide don't show. Okay, well, thank you and love you all, guys. Thanks for your time.
Any other judge comments before we wrap up?
That was a very nice presentation. Thank you, guys.
Thank you.
Thank you.
Thank you, Team Coopel. Next.
All you need is love.
Next we have is Team A47, a few college students. And after that, we have Team A017 Proact.
Hey, Fatima, quick question. Before we start off, are you using headphones?
No, I'm not.
Okay. For our presentation, we have our video embedded, and we figured out with our problem with our audio is that I was using headphones, so no one else really could hear it. If you could put the audio up on your device a little bit louder, we'd really appreciate that.
You can also share the audio from the computer directly, Fatima, in case.
Okay, yeah.
Yeah, it is. I have it on those settings. Is it really hard to hear me?
I can hear you. Yeah. It's just for a video in case like we ran into a problem over practice where we couldn't hear it.
Okay.
Perfect. I think everyone else on our team is here. Yeah, we're good.
Okay. You can go ahead.
Perfect. So we are a few college students, and we're here just to try to tackle our perspective using from our education to understand what exactly goes to help fight the COVID-19 pandemic. Next slide, please.
Okay, so we're going to start out by defining the problems that we're trying to solve. So first off, non-COVID healthcare. There are a ton of like non-COVID patients still seeking assistance, and they don't really know which medical centers are safe to go to based off like how many COVID cases they have. So that's why we included hotspots. And then avoid infection risks. Obviously, in-person visits increase chance of exposure. So we had a symptom checker to mitigate unnecessary visits. And then just debating in-person versus telemedicine. Telemedicine is usually faster and cheaper than in-person, but it's hard to know when it's appropriate to use telemedicine versus whether it's severe enough that you have to go in person. So we kind of want to address all three of these main issues. Next.
So we have the opportunity to reduce the COVID-19 spread by limiting the wait time in facilities. The average general wait time in a facility in 2018 was 18 minutes. And 30% of those patients measured left due to a long waiting time. Limit space due to social distancing. 6 feet social distancing reduces usable space significantly within a facility and limit potential spread of germs. Fewer people in the office space simultaneously, and in addition, extra items require extra cleaning. Next.
So here's a customer who'd use our product. His name is Jagmir. He lives in Queens, New York. He's 19, a Gen Z demographic. He recently broke his pinky in the pandemic and then woke up with a sore throat but no other COVID conditions. So he's really debating, should he really go in and get checked up and maybe scared of getting COVID? So on the next slide, we can see the product demo. So next slide, please. And here's a product demo.
We start a demo at the main menu. The first option you can choose is to fill out the general questions that one receives at a normal visit to the doctor's office. After entering your name and date of birth, you are given these questions to fill out. At the end, you are provided with a QR code that contains the information you entered to show the receptionist. Next, you can choose to check whether or not your illness requires you to go in person for a doctor's visit. For the sake of this demo, let's assume you might have strep throat. The questions will adjust based on what you answered. At the end, you are provided with another QR code. Another feature is a database that stores your insurance cards in a digital version. Finally, you are able to track cases of COVID-19 in counties near you. This example shows that you're searching in Queens, New York. That wraps up all of the features for our prototype.
And that wraps up our pitch. And if you have any questions about our product, we'd love to answer them.
Thank you, team.
And then these were some screenshots we had in case the video didn't work.
Okay, great. The floor is open to judges.
So we're like a broken record kind of, but can you guys talk about the competitive landscape a little bit?
Yeah,
definitely. So I can talk about that.
Patrick.
Yeah, so I was the one that kind of made that the whole video. So if you recognize my voice, that's why. But essentially, we identified two different competitors in this space that are pretty strong at the moment. So you have ClearStep, and you also have SupDoc. Both currently are mobile applications at the moment, and they both have features such as like symptom checkers, or also talking to AI dialogue and being able to find the right point of care. And both of them kind of just solve the issue of no need to go in person. You can just do it over the phone. But these these other competitors don't exactly hit on the other issues that we identified in our problem. So you know, like besides in-person versus telemedicine, we have kind of how do we avoid the infection risks and also non-COVID healthcare. So we want to like focus which medical center is relatively safe through hotspots. And that's what we kind of wanted to include in our application, just to make the whole process a little bit more seamless.
Just one point, your comment on safety, I wouldn't necessarily equate safety with COVID prevalence, either at a facility or city or county basis. You know, one facility might have many COVID patients, but is super well staffed, very expert in handling, versus another facility that has less but doesn't handle as well.
Yeah.
Right.
And I think the point to that was just saying, like, it gives the patient kind of perspective, like, this is a risk you might be taking eventually. Like, people, for example, who live in Queens, New York, or in New York when the outbreak happened, they really couldn't go anywhere else, but they knew like this was happening in their city, and it's just an extra risk that they were willing to take. So it just kind of informs our patients to say, if you're willing to take this risk to get checked out.
Understood. Some provider groups might have the same point that I did. It might make it challenging for them to want to sign on then. You know what I mean? To give data for it.
Yeah, the issue about like privacy and data privacy, and also just a seamless integration is definitely of concern and something that would need to be worked on.
Yeah, and this is just as our minimum viable product, something we want to go to show what would be our next steps and where we can improve on.
Okay, thank you, team 47. Next
Cool, thank you.
Thank you.
Next will be team A17, Pro X, and after would be A21, Connected Health.
Yeah. Am I audible?
Yes.
Yeah. So can I start?
Yes, you can start.
So yeah, Yeah, hello everyone. I'm Saharsh Pamecha and will be presenting on behalf of my team ProActX. Next. Due to pandemic scenario, the sufferings of non-COVID patients did get neglected. Many healthcare centers recognized a rapid decrease in the number of non-COVID patients. Next. Number says that around more than 50% of the regular patients of the hospitals and clinics just got cut off from them. Many patients are in a dilemma whether to visit a doctor according to the symptoms or not. Will it be safe to go in such a scenario? Next. Here we come to bridge this gap. Using the current technologies, we aim to build mobile and web interfaces to help out non-COVID patients. Next. The application promises to be as interactive as possible and have lots of functionalities to help the users with their most concerns. Next. One of the key functionality is online scheduling. Just by clicking some buttons and checking some of the boxes, the users may get comfort to connect to his or her desired physician or therapist. Next. Other key functionalities. Next. Other key functionality include educational interface. We believe in educating the users so that they might get a better understanding of the condition and be more specific when communicating it to the concerned person. The application will also include some of the first aid measures by identifying the specific problem and how it can be dealt safely till get some personal advice. Next. Some of the key points. Next. Some of the key points to highlight about the technical aspects are the application will focus on providing the personalized experience to the users. All the data collected, processed, and interacted with will be stored safely in the cloud database. The algorithms running at the backend will automate most of the tasks and will help the user to get updated. Next. The key benefits using our application will be, we will always try to deal with the user problem from its grassroots level and will not leave it until it is fixed properly. We'll also make sure on the ground level that there are least chances of exposure to the infectious diseases by shuffling the schedules of COVID and non-COVID patients. Next. The diagrammatic representation that is displayed here, this is the development cycle that we are planning to follow up with. Till now, we have covered the 2 levels. Also, during the hackathon, we have developed several algorithms focusing on how a diabetic patient would interact with the system from screening to consultation, follow-up, and home management. Next. So here is our team with diverse backgrounds, but sharing a common goal to work on. We all are working with one aim to make healthcare more convenient, promising, effective, and affordable for every living being. Thank you. We are now open to the question.
Thanks, Team ProActX. The floor is open to judges.
So thank you. Very nice presentation and very nice focus on the person as an enabled player in the system. Would you see also a possibility to connect your solution with emergency services or rescue systems in case of need, or third parties?
Ma'am, your voice was breaking. I couldn't hear completely, but what I could understand was how we can connect our system or how we can connect our ideology with existing systems.
There was, sorry, you hear me better?
Yeah. And now it's
okay. Are you planning on potentially connecting with emergency services or third party, being able to act as rescuers or
exactly.
rescue teams?
Yeah, ma'am. We have added the point in our application and in the slides as well, that we will be connecting our application to the emergency services, the transport facilities, and also the testing and the hospital and healthcare system. So it will be a full-fledged solution for a user to get some personalized comments, the reminders of the medicines, how it can be more better, and how to avoid the physical interaction while getting a more efficient and more better way of a telemedicine at a home or at the same place itself.
Thank you.
Thank you, Team Pro Act X. Next, we have Team 821, Connected Health. And after that, we have, see who else we have after that. Alpha 11 already went, so Alpha 11, you won't be going again. But right now, next we have Team A21, Connected Health.
Great. We can start on the next slide. We are Connected Health. The picture you see is India's government hospitals pre-COVID. With less than 1 bed per 1,000 patients, the Indian healthcare system was already overwhelmed. Now, with 2.1 million individuals expected to be infected with COVID by July, and majority of Indians without access to telemedicine, the healthcare system is crashing. Next. Unsurprisingly, the greatest impact of COVID-19 is on low-income individuals such as Rekha here. She does not have access to a smartphone or to internet, nor does she have a reliable centralized hotline protocol. With limited clinics providing services, Rekha and 770 million others like her do not know who to contact, what to do, and where to go. Next. This is where we come in. Collected Health allows us to answer these questions by identifying at-risk patients, triaging, treating using phone-based consultations, and distributing patients based on hospital availability and fit. Connected Health is targeted towards low-income individuals like Rekha, with its IVR platform available in 8 local languages and no smartphone or internet required. Next. To answer the question, what do I do? Patient symptoms are evaluated using a combination of IVR and, if needed, telephone consultation. Following triage, recommendations are made for home-based or symptomatic care, in-person clinic visit, or hospital admission. Next. Next, we answer the question, where do I go? In the back end, Connected Health collects information regarding facility occupancy status and other criteria, such as COVID management capacity. Using this information, patients will be sent a list of facilities which are closest and best fit, therefore saving valuable time in case of emergency. Next. In phase 1, we will rely on donor grants and partner with the Government of India to supplement their current contact tracing application. We will start with public health facilities on our platform. While phase 1 will involve manual data collection, phase 2 will have real-time data gathering from hospitals. Phase 3, which also includes monetization, will involve a fee-based model with private healthcare and insurance companies. Next. Connected Health team comprises of leading medical experts in India and technology consultants who understand the pressing problems low-income individuals like Rekha face and are determined to make a positive impact. Thank you. We're Connected Health. Stay connected, stay healthy. We're open to your questions now.
Thanks, Connected Health. The floor is open to judges.
Thanks so much. Can you speak a little bit more to the VIR aspect of the service and how you guys would develop it anywhere with that? IVR, sorry.
Yeah.
So I can answer that question. The focus of the IVR would be to identify 3 things, basically. Number 1 would be to kind of delineate what kind of illness that the person is suffering from. And considering that there is a lot of COVID in my country right now, we would have a questionnaire based off of the WHO COVID-19 questionnaire, and also a triage questionnaire that we've developed, which is being used in the city of Mumbai right now. So combination of that to kind of understand whether the person is at risk of developing COVID. And secondly, we would also look at the non-COVID related common chronic health, chronic diseases such as COPD, asthma, diabetes, hypertension. And at the same time, we would like to ascertain what level of care the person would require based on the current symptomatology, and where would and we would find out more information regarding his location through the IVR in order to better guide where he or she would have to go.
How is the IVR being presented to them?
I'm sorry?
How is the interactive voice response, the intake, the survey, how is that presenting to them, to the patients?
Right. We will have a phone number that anybody can call, and through the IVR, we have a series of questions in a decision tree format through which they can move ahead.
Got it. And the other data that you had about number of beds available, number of ventilators available, is that actually digitized and you're able to pull it from somewhere, from a central point?
Right. So that is definitely going to be a challenge. In phase 1, we don't have dynamic data like that. We will have static data with regards to the status of the hospital, with regards to whether they are accepting COVID patients or not, whether they're accepting only non-COVID patients, and with regards to the level of care, all of which is available publicly in government databases. And in phase 2, we would like to collect real-time data, and considering that all of these spaces don't have electronic health records, what we hope to do is have a simple phone-based application, a smartphone-based application that would be handed over to the doctors or nurses who are in charge of the wards, where they'll update the number of patients.
Okay, great. Thank you, Team Connected Health. Next up, we will have Team A40, Guardian Health Remote. I'm going to give you guys a few minutes to collect yourselves. And after Team A40 Guardian Health, it will be Team A1 Maridi. So Guardian Health Remote, just let me know when you're ready.
I think there's someone that's not on our team that's not muted.
Who is it?
There's actually a few people.
Okay, thanks.
Sanish. Okay, yeah. And then Sarah's not part of our. Sorry, Sarah. Andrea is part of our group, though.
What was that?
It's Andrea, Fatma, Bassam, and myself. Thank you.
Okay.
Can you guys hear me okay?
Yes.
Great.
Okay, we are ready when you are. Thank you. Good afternoon and welcome to Guardian Health Remote Analytics, the future of hospital. Next. "30-day hospital readmissions have massive implications for patients and providers alike. Since 2012, hospitals have forfeited nearly $2 billion to reimbursement penalties." Next.
Meet Phyllis, my grandma, and also one of our potential users. She says, "I feel like a recluse in my own home. It gets me very depressed. I have a lot of pain in my body, and the depression from COVID makes it worse." This user has been readmitted to the hospital 2 times in the last 30 days during COVID, and was actually readmitted a 3rd time following this interview. Next. Our prototype is a circular regenerative systems design. It focuses on remote monitoring coupled with machine learning predictive analytics. We start in the upper left corner with discharge and data integration into the take-home device, which connects to the patient's medical devices. Then, due to daily interaction with the device, machine learning adapts to variations. In Phyllis's case, she has minimal dexterity and low mobility, so the voice activation would provide great usability and ease of communication. After connecting with her primary care provider and confirming good health, the device would be returned to the hospital, similar to how Rent the Runway and textbook rentals operate. When the patient returns the device, it would be incorporated into the hospital's medical equipment sanitation cycle before being re-administered. Next. Our core competencies that set us apart from other healthcare competitors are AI predictive analytics for automated interaction paired with voice control and a chatbot feature. We are taking a holistic approach to our design that includes multiple access points because we found that vocal AI is more accessible than applications. To address and mitigate COVID fears, all facilities in the Guardian network are pre-vetted to ensure safety and sanitation compliance. Next.
Our value proposition centers around sustainability, scalability, trust building, and risk reduction. With a 30-day readmissions reduction of just 10%, hospitals can enjoy an estimated $1 billion in revenue savings. Next. We anticipate an expedited market rollout due to high demand from the pandemic. The prototype to implementation phase may be realized within 6 months. Next. Thank you all so much for your attention. We would love to answer any of your questions.
Great, thank you, Team Guardian Health Remote. Before I open to judges.
Thank you guys, that was a nice presentation. Did you say that you connected to healthcare providers? I missed that part.
Yes, so there is a trigger to a remote registered nurse in triage offsite who is taking in any types of trigger alerts that are basically a deviation from a patient's own baseline metrics. For example, we configure a 20% deviation from a patient's baseline. The predictive AI can predict deterioration before a patient even feels symptoms, because we don't want to wait until they're symptomatic to alert and escalate to either urgent care, physician's hospital, or emergency department, and also get them to the right center as well.
And are the devices passive? Are they all sort of smart home devices, or do you have wearables as well?
We decided not to go with wearables due to non-compliance and also artifact. Right now, we still just see a lot of artifact with wearables, even in the hospital.
Yeah, and connecting to the users even more, the people that we interviewed also felt that the wearables there was like this stigma associated with it, that when they're wearing it, like my grandma has a life alert and she hates pressing the button and she hates wearing it around her neck because it's visible and people can tell that she's ill.
Any other questions?
Sorry, last question. Who's paying for this? Is it the patient themselves, like a subscription fee?
So we've been kind of playing with that, and I think that's definitely next steps for us to figure out. We've kind of centered on people who are interested in investing in the future of hospital, which is pretty hot topic right now, along with like future work, these futuristic settings. And I think that coupled with possible sponsors and partners, we've also talked about if they take home the device and they want to keep it, like someone like my grandma has 3 visits in a month, maybe there's a way for her to hold on to those devices and she can kind of work with her insurance providers and buy one of those for herself.
Right now.
Right now.
Is approving these take-home monitors as a medical device. So most of the revenue is captured through the telehealth visits and private and commercial and CMS.
Okay, great. Thank you, Team Guardian Health Remote.
Thank you.
Thank you.
Thank you. We have Team A1, Maridi, and this is the last team that's going to present.
Hi, this is Sarah Covington. I'm ready for the next slide. Hi, we're Team Maridi. Next. Many medical practices are struggling financially as volume has dropped over 50%. Previous slide. Meanwhile, patients need preventative care but are worried about coming on site due to COVID. 65% of patients like the convenience of telehealth, but these platforms do not provide the biomarkers needed to conduct annual and preventative visits. This is apt for patients such as pediatric, pregnant, and those with a chronic condition such as diabetes, which impacts 34.2 million Americans. Next. Our solution provides clinicians with necessary biomarkers to conduct billable virtual wellness care, facilitating convenience using only a smartphone and watch. An AI-powered medical scan will generate pulse, SpO2, BMI, BP, and blood-free glucose readings. Pediatric patients will be routed to the clinic for immunizations, and general guidelines will alert out-of-range metrics, which is supported by Uber Health and emergency services integration. Next. Marie has diabetes and is in postpartum. Please play the video. She's been stressed during the pandemic, so her doctor is conducting a wellness visit remotely, given the key biomarkers generated, combined with the existing mental health assessment, telehealth, and EMR integrations. Patients simply place their finger over the phone's camera and flash to test their glucose, meaning patients will no longer need to prick their finger or wear a sensor. This is possible through cutting-edge research on a glucose scan using light penetration rather than the traditional enzyme reaction with blood. Then the phone's camera measures BP, pulse, and SpO2 in a matter of seconds. BMI will be calculated utilizing image, sensor, and machine learning algorithms. Next. The MVP will take 7 weeks. There's ample feasibility research for developing BMI, BP, and glucose readings thereafter, though we can include an additional device if needed to mitigate risk. A future feature includes embedding the scan into a game geared for the pediatric population to enhance virtual care, as 64% of parents polled have used or plan to use telemedicine within the next year for their child. Next. For market entry, we are partnering with AlertEase, an RPM company, for the data to train the algorithms by aligning the manual metrics captured with the scan results, thus providing the basis for seeking FDA approval. Thereafter, our $2.6 billion market includes physicians, telehealth platforms, and a patient subscription model representing a conservative 30-year revenue estimate of $10 million. Companies like Bana and DigiDoc have similar early-stage projects, but Miridi is differentiated by the inclusion of glucometer readings and BMI calculations, providing solid IP. Next. Our innovative team is physician-led, business-focused, and supported by tenured AI and machine learning development. We are each committed to bringing this product to market and seeking venture capital support. Next. Any questions?
Thank you, Team Miridi. The floor is open to judges.
So on the sensor piece, did you evaluate how long it would take to get that approved? No, it's a very nice concept. It's just that I want to make sure that there is no misunderstanding on what even a medical device approval path is.
We understand it is a longer road with the FDA, and that's why we are starting out by pairing with a remote patient monitoring software company. That way we can begin the scans right away, collecting the data needed. So the product will be in the market, just not used for medical decision-making processes until it is FDA approved, because that is a critical piece to patient care.
Okay, thank you.
So would you guys be using off-the-shelf devices to get BP, SpO2, BMI? Because those don't need to be regulated.
Correct. We're actually going to be just doing a scan from the smartphone to collect those pieces of data. That is how our competitors, Bana and DigiDoc, are presently performing.
You mentioned the pediatric, was it gamification piece? Could you speak a little bit more to that? Is this specifically targeted to the peds market or more generally?
This product is applicable generally, but we wanted to incorporate this into the game for the pediatric population specifically as a longer-term solution, particularly for adolescent patients with diabetes. I was doing some research with patients and got to hear the story from a mother whose 2-year-old has been diagnosed with diabetes. And listening to how she had to hold down her child during finger sticks was extremely heartfelt, and something that this product, while it won't be able to solve it in the timeline of her own 2-year-old having to go through that, can solve that painful experience for many other adolescents in the future. So it is a longer term strategy, but I think it's important to incorporate and be thinking about.
The blood glucose monitoring piece that you mentioned, I know you cited the research, but is that something that you will be developing?
It is something we are working on developing. It's not a part of the MVP. Our MVP is more aligned with what our other competitors are currently offering, with just using the smartphone to conduct the scan for the Pulse SpO2. And then from there, we're going to move on to BP. One of our close competitors, Bana, is currently also working on BP, but theirs is not yet finalized. The BMI will incorporate the use of the smartwatch. So once the BMI piece is ready to launch into the market, we'll incorporate that component and then continue on to include the glucose monitoring.
Any other comments from judges? Okay, great. Thank you, Team Mariti. And that concludes this pitch session, the final pitch session. Thank you, everybody, for your hard work. It was demonstrated through your presentations, and the judges will now deliberate, and we will see you in the end program.